The topic of this presentation is the emergency implant, the immediate extraction replacement. And when a patient presents themselves to your office in an emergency situation, it may be that they have a fractured or a non-restorable tooth in the aesthetic zone, and they certainly don't want to have to be in public and social situations, job, whatever, in that situation. So when presented properly, the implant option of a dental implant is the best option for that patient, because if you present a 3-unit bridge and tell them that you have to prepare adjacent teeth, or the possibility of wearing a flipper, which may alter the speech temporarily, generally the implant again is accepted, and basically you're taking an office emergency and turning it into a service that's going to result in profit. So in other words, the decisions that we make is extract or not extract, and that is the question. So in my practice, we don't try to save compromised teeth that do not have a good prognosis, as in that case the patient may be going through some expenditure of time and cost and not having the desired results for any length of time. So our consideration is evaluating from a periodontal situation, an endodontic consideration, caries, is this tooth restorable? What do you have to do to make it restorable? And it can be the implant could be an alternative to crown lengthening, which again could be into added expenses, and by the time you go through all of that the implant would be about the same cost to the patient and with something that's much more predictable. So again, we look at the emergency implant, extracting the hopeless tooth. We clean and prepare the site for the implant. We graft any fenestrations, and most of the time when we take out an endodontically treated tooth, there is a fenestration. And we're going to go through the discussion on the preparation of the site, the insertion of the implant, making sure that the system that I use, which is replace, select, or in the last year we've been also using some Noble Active. Again, both of these are tapered implants, and we're looking at primary stability of 35 to 45 Newton centimeters. We can place an abutment, and we'll discuss the abutment options and the provisional crown. We'll talk about the fabrication of the crown, the handling of it as far as the occlusal aspect, and adjusting it 1 millimeter out of occlusion, and seating it with a good provisional cement if we're using a cement type restoration, and being sure that all the cement is removed. So the principles of immediate implant, which we must follow in order to get repeated predictable results. And this is something that I've been doing for many years, and when we follow these principles, that we do have long-term predictability. So we're going to discuss some different methods of extraction. There should be no active pathology. In other words, if you remove the tooth and there's exudate, you would probably going to have to consider a delayed extraction replacement. We're going to clean the site well. The patient's going to be on antibiotics, and in that case we may have to make an alternate type of a provisional. The implant can be longer than the tooth you're replacing, so you are improving crown-root ratio by 1 to 2 millimeters. There should be no contact of the implant to the thin facial bone plate, and we'll discuss the method on how to avoid that pressure contact. We're going to use the thread former or the screw tap against the palatal wall. Now, the palatal wall is denser and thicker than the thin labial wall. And if you don't thread form and using a threaded type implant, that the palatal wall will influence the implant and push it against the thin labial wall. And many times you don't see that until it's too late. In that case, you're going to get labial bone resorption, and the tissue will follow that, and then sometimes you're going to have thread exposure. We want to avoid that. And before or after you place the implant, depending on the situation, we want to seal any gaps or fenestrations so that we do have some intimate contact all the way around, filling the spaces between the implant and the bone. And sometimes we use a bone slurry or a gel, and we'll give some examples of that through the presentation. And sealing that circumference of the implant gently, we've coined a term called socket seal. So our abutment options for the immediate provisional restoration, we can use specifically designed abutments for temporization. There's a temporary abutment. There's one that's called a quick temp abutment. Those are from Noble Biocare. Other implant companies, I'm sure, have something that might substitute as temporary abutments. We can use a final titanium abutment, or we can use a ceramic zirconia abutment, depending on what you're comfortable with and what you're really trying to achieve. And again, through the presentation, we'll give some different examples. So again, we go back to the principles because it's very important. Now, the extraction is one of the most important steps because we want to be careful not to fracture, if it's a anterior maxilla, the labial plate. And we want to remove any existing pathology. And sometimes you can also clean the alveolar socket using like a CO2 laser, whatever some of the things that you use in your practice to debride the socket, curettes and what have you, but it's got to be perfectly clean. There cannot be any soft tissue. We want to check for any fenestrations, so we can take our curettes and place it against the labial wall in the socket and feel with that curette if there's any fenestrations and basically holes in the labial plate. We want to select the implant and diameter that will avoid contact with the thin labial plate. One of the kind of misnomers in immediate replacement is doctors felt that they had to fill the whole socket with metal, and that's where the problem begins. You want to have some spacing between that labial plate and the implant. Now, the implant achieves its stability from the mesial distal and palatal wall, or lingual wall. And we want to keep the preparation along the palatal wall. We want to keep the implant more against the palatal wall in sort of a vertical position, so that you also have the opportunity to use a screw-retained abutment. Now, very important that we use the thread former if we're using a threaded type implant and not a self-tapping implant that has aggressive threads. But if we're using a tapered implant or a parallel walled implant that's basically a threaded implant, we want to be sure that we use the thread former along against the palatal bone so that that doesn't influence and the implant can go in without being pushed against the labial plate. And again, if there's fenestrations on the labial plate, I like to put some grafting material against that wall before I insert the implant. It's easier to fill it at that point. And then if I have any gaps between the implant and the walls of bone, I can, after the implant is placed, then I can take a small instrument and place some graft material in that area. So again, thank you for looking at this presentation. I hope that this will clarify many questions in your mind about immediate replacements, and it's a modality that your patients appreciate, they talk about. It's a way to do marketing, because most of our patients that we do this do talk about it, especially in social situations. So thank you again, and have you safe journey in implant dentistry.
For more education programs, visit the GIDE Institute at www.guidedental.com.